Hello and welcome again to another edition of Matters of the Heart, brought to you by Pentucket Medical Associates Cardiology and Haverhill Community Television. Today I'm with my associate, Dr. Srivastava, and we're going to be talking about a disease entity or a problem that we haven't discussed, a problem with the heart valves, a common problem that we see in elderly patients. This problem is called aortic stenosis. So tell us a little bit about your thoughts on what we can teach the public about aortic stenosis.
Sure. Thank you. As you mentioned, aortic stenosis is a valve problem. And to start, it probably makes some sense to talk about what heart valves are and what they do in the heart. And so I have a graphic to show that maybe help explain this. It details the anatomy of the heart. So maybe we could put that up. And this may take a few minutes to walk through this. It's a little detailed, certainly. But the heart is made up of four chambers. There are upper chambers called atria, and there are lower chambers called ventricles. And there are valves between those chambers that just act as doorways to regulate blood flow through them. And so on this diagram, on the left side of your screen, you see two bluish veins going back to the heart called the superior vena cava or inferior vena cava. And they bring back blood from the body after the body has used up the oxygen, and the blood enters into the right atrium. It's one of the chambers. Blood then flows through the heart through a valve called the tricuspid valve, and that acts as a doorway. It opens and closes to let blood go through. And the blood ultimately works its way through the lungs and back to the other side of the heart, which is the left side of the heart. But on this diagram, it's on the right side of your screen. And ultimately, when the heart is ready to pump the blood out to the body in its oxygenated state, it goes through the last valve. It's called the aortic valve. And that is the valve that helps control the blood flow from the heart out to the main artery of the body called the aorta. And then that delivers blood to the rest of your body where you need it. That valve is typically made up of three leaflets, and so it's referred to often as a tricuspid valve. So a cusp is a leaflet. And so it's...
Let me just ask this to make sure I get it so that we can review for the audience. So basically you mentioned that there's four chambers, which are like rooms that the blood flows through. So blood sort of goes from room to room or chamber to chamber. And the separation between these chambers are the valves.
Just like doorways.
Like doorways, exactly. So when you leave one room, you close the door and go into the next room, and blood sort of progresses through these different chambers.
Right. And if functioning properly, the door closes and nothing goes backwards. And if functioning properly, the door opens well,
fully.
And you go forward properly.
Okay, great.
Absolutely. And this is where, go ahead.
So one of these valves that we're talking about today is the aortic valve, which is the sort of final door, the final exit door, like the front door going out of the house.
Yep.
So we might say it's the main outlet valve of the heart, going out into the main pipe of the heart called the aorta. So we're talking about that as the valve we're talking about is called the aortic valve today.
Right.
Okay.
Right. And so, of course, there are other valve problems, but we're going to focus in on the aortic valve today.
Okay.
And it's obviously, well, maybe not obviously, but it's an important valve as it's the outlet valve and regulates blood flow to the body. And there's a condition that's well described and well known and not uncommon called aortic stenosis. And that's a fancy way of saying basically that the valve is narrowed or doesn't open as well. So that door does not open well. It does not allow blood to exit as well as one would like it to.
Okay.
And it is more often than not a disease entity associated with aging. It's said that once one is 65 years or older, 2% of the population will have this condition. At age 75 or older, it's 3%. 85, it's 4 or 5%. So it increases with age.
Sure.
And
but as you said, not insignificant. So 1 out of 50 people over 65 will have it.
Yeah,
so
and that's a lot of people.
A lot of people.
So no doubt about it. I think not a day goes by in the office where I don't see somebody with some degree of this, certainly.
Okay. So over 65 too, and so I guess we'd also might say that the thing that's happening here is that the valve is, instead of, if we think about sort of what happens to other tissues in human life, we think about an infant, how the tissue has such soft and supple tissue, and then sometimes older individuals, even the skin might be a little more firm, less soft, and that's actually what's happening to the valve.
That's precisely what's happening. As we age, the valve acquires, calcifies or thickens and doesn't open as well. And a lot of that is due to turbulent. There's a lot of blood flow going through there. It's turbulent, and over the years, the calcium can deposit there and cause it to thicken.
So calcium's something that's made you can make salt or crystals out of, or stone. So it's actually like almost like a petrification, like a petrified forest. So it's hardening this tissue that's normally very soft, like very soft skin, becomes very thickened, and that's the process we're dealing with here.
Exactly, and this, it gets worse as we get older, certainly.
Okay.
And that's the most common cause of this, by far, the most common cause of this. There are other entities that can cause this as well, and one of them that is well known and not uncommon either is something referred to as a bicuspid aortic valve. So earlier I had mentioned that the aortic valve is typically made up of 3 leaflets, tricuspid valve. Rarely, it's not so rare actually, in about 1 to 2% of the adult population, they were actually born with an aortic valve that has 2 leaflets. Okay. So it's referred to as a bicuspid aortic valve. So you may ask, well, what's the big deal? It doesn't make a difference, 2 leaflets versus 3, but it does make a difference. The way the blood flows through there alters the local hemodynamics and the turbulence that's generated there, and that can lead to premature thickening and restriction of those leaflets as well. Okay. So for the most part, if one has a bicuspid valve, or these 2 leaflets, they end up doing just fine, that they may not have any problems and may not ever really know about it. In fact, about 2/3 of folks with it have no problems whatsoever. The other third can ultimately develop a narrowed valve, or stenotic valve, as we refer to it as, this problem, aortic stenosis. Actually, I should rephrase that. Another third develop a problem with the valve. Some people can develop leakiness of the valve as well. We're not going to get into that too much right now, but some people can develop leakiness. Some people can develop narrowing as well. So those are the 2 most common causes by far, and really I think encompass the majority of cases. There are other rare causes that people could have, where if they've had rheumatic fever as a child.
Very uncommon in our country.
Right now, it's very uncommon, especially with the advent of antibiotics and how frequently people take antibiotics.
So rheumatic fever is something that was more common in earlier part of the last century in the United States from a kind of bacteria, from streptococcus or strep infections. Right. It struck fear in the hearts of our grandparents and our great-grandparents, but with the advent of antibiotics, we don't see it anymore. But we do see it, as I know you're familiar with, in some immigrant populations from Asia and South America, where there isn't the same availability for antibiotics.
And I think the most common valve affected by that is usually one called the mitral valve, a different valve here, but it also can affect the aortic valve as well. You often see both valves involved, certainly. So I haven't seen a lot of that around here recently by any means.
So basically, just to review what you said, and maybe we can show the graphic while we're talking here and look at the graphic of the aortic valve, the next graphic we have while we're talking. But there's 2 main types of aortic valve problems, I think you said. Yep. And on the top picture, I think you've already discussed in great detail, a normal valve that has 3 leaflets.
Right. And that picture shows it wide open. It's open and the blood's flowing through. Right. And then on that same graphic, just below it, there's the one, it looks almost like a
football shape.
Yeah, it's standing on end, getting ready for a field goal attempt or something. So it's and those are 2 and that again is open, with the blood going through as well.
So the one on the top, 3 leaflet valve, if that was going to get to be a problem, the most common thing would be to happen in an older patient, over 65, over 75. We have patients we're following in the 85. I have several patients I'm following in their 90s who are walking around doing great, but have this problem with older patient aortic valve narrowing from what was a normal valve at birth, but now has gotten thickened. Right. And the other thing that you showed in that graphic, and the other one, was in a patient who was born with, instead of these 3 leaflets, which is normal, or tricuspid, 2 leaflets, which is the one that you showed there with what looks like the football. And because of that sort of fish mouth opening, there's a likelihood of scarring. Tell us a little bit about when those patients might show up with trouble.
That's a great question, or a great point, that it's a little different. So you're born with that, and more often than not, you aren't aware of it until it's picked up. And we'll talk about how these things can get picked up upon. But these can develop problems at a slightly younger age. More often we talk about people in their late 40s, early 50s often developing problems. And ultimately, if these folks need something corrective done, a surgery done, it's often done at a much younger age than the other type, the calcifying type.
So what decade of life are you talking about?
So usually late 50s or early 60s.
Okay,
is
so much earlier.
Yeah, so much
20
earlier,
years
certainly.
or so.
Yeah, absolutely, much earlier. And so it's important to make the distinction, to know the difference between the 2, certainly.
Okay. All right.
So I think maybe a next place to go with this and talk about this is how do we pick this up, or how do we diagnose this?
Okay.
or maybe we should even talk about what the symptoms are people might have. And so more often than not, when you're picking this up, I think people don't have any symptoms often. And they go see their doctor for a routine physical exam. And part of that exam involves listening to the heart, of course. And there is a certain characteristic heart murmur that we can hear that's often indicative of this problem.
Okay, so let's stop there. You just used a word that often brings up questions in the office. You just used this word. It's murmur. What is a murmur? Is a murmur always a bad thing? Is a murmur a sign? Just tell me some general thoughts that the public should know about if they hear they have a murmur. I have patients say, I've had a murmur my whole life, so therefore it's meaningless. I have to correct them on that. Some people have said, well, I have a murmur. Does that mean I'm in bad shape? Just help us understand that.
A murmur, all it is us physicians listening to the heart and hearing turbulent blood flow.
Okay.
And the blood can be turbulent in different parts of your heart for a variety of reasons, many of which are very benign and very innocent, and some of which can be problematic. Some can be there just because your heart's beating fast and you're active and exercising. You can have a little, what we call flow murmur, very benign and innocent and of no consequence really. There are certain characteristic changes that we can hear that could be signing to us that it's something more significant. So I guess people could certainly have heart murmurs their whole life, and they could be benign or not benign. They could be a problem or not a problem. People could have murmurs later in life that are not a problem, or it requires more than just
so
saying
it's a physical exam sign heard with a stethoscope. Is that sort of the simplest way we could say that?
And it's just representative of turbulent blood flow.
Right.
For whatever reason.
So when the doctors are listening, I sometimes say to students I work with that the normal heart sounds, I think people know from their childhood learning in school that the normal heart sounds are lub-dub, lub-dub. Those are the two doors closing. The valves are closing. Lub-dub are those two different valves closing, two sets of valves closing more accurately. And if we hear a murmur, it might be a noise between there. So it might be lub-should-dub, lub-should-dub, lub-should-dub. Right. And that's the noise, the sh is the murmur that we're hearing. And as you said, I think very well, it could be benign, not meaningful, especially in a young child who has a thin chest and we can hear very well. It might be, as you said, an innocent murmur or not significant. But it could be significant. So take it from there. So now we know what a murmur is. The doctor heard it. What do we do then?
And so I'll stick to the case of aortic stenosis, just for the sake of this discussion. And there are certain symptoms that we would often ask people about to see if there's a significant degree of narrowing or stenosis. To back up, people can often have sort of vague symptoms. It can be from anything. You could be fatigued or just not as energetic as you often are. But some of the hallmark symptoms or textbook symptoms, people can develop chest pain or angina, pressure in their chest when they try to exert themselves or do something. They could develop shortness of breath or fluid retention, also referred to as congestive heart failure. And it could be so serious enough such where they could pass out, actually.
Faint.
Faint. And the fancy word we use for that is syncope, but passing out or fainting, exactly. With exertion, more commonly, what we're talking about. When people try to do things,
all of these signs, which we know, if they're being caused by this problem, is failure for the heart to get blood out that main outlet valve. So the outlet valve is stuck, the person's working hard, and they faint because enough blood's not going to their brain, for instance, as an example.
Right, the same thing. And just like with the angina or the chest pain, the heart has arteries as well that the heart needs oxygen to pump strongly, and those arteries aren't getting the blood it wants either. There may be some other causes for it as well, but that's the easiest way to really get at it, that the heart valve is not opening enough to allow enough blood flow out to meet the body's demands and needs. And also, consequently, you can think of it as things backing up in the system, and that's where the fluid retention comes into play as well. Okay. Those are serious symptoms. If one has those symptoms with these underlying valve problems, that can often be the need to intervene upon it, meaning corrective surgery, which we can talk about certainly. Okay. Other symptoms that we should talk about? I think those are the main hallmark symptoms and sometimes it's a little tricky as one gets older. People are in varying states of health. Some people may not be as active, more sedentary, so it's a little tricky sometimes to really tease out those symptoms with exertion. Right.
I think the biggest one that's difficult to tease out, as I'm sure you're familiar with your own patients, is the issue of shortness of breath, because patients can often attribute it to that they feel like they're getting a little older or they're out of shape, and those can certainly be explanations, but it could also be for this underlying problem, and that's really makes it difficult for us, and we have to be candid with patients. We can't always be sure.
Right. And so the next step from here is often some diagnostic tests that we take care of. And I think I have a graphic prepared just to show some of the different tests that we routinely do.
Okay.
And it all starts with the physical exam. So obviously keeping frequent visits with your doctor is very important in general for screening these types of problems. And when you're at the doctor's office, you often get an EKG. And that's what's depicted in the upper left corner. And an EKG really is just checking the heart's the heart has an underlying electrical system, and this is looking at that electrical system. It can pick up a lot of different things. It may very well be completely normal in somebody with aortic stenosis, but sometimes people who've had this heart valve problem, because the heart's working harder, the heart muscle can thicken a little bit, and you can see that on an EKG. An EKG is very simple. It's done very quickly in the office. Patients will often just have to remove their shirt, and they'll have electrodes, little stickers placed on their chest, and takes just a few seconds after that's done, and you get the snapshot, which provides us a lot of information. People will often be referred for chest x-rays, for example, when they complain of shortness of breath. And in aortic stenosis, the chest x-ray may be completely normal. It's quite possible. But you can also sometimes see, as an indicator of the underlying problem of calcification, you can actually sometimes see the calcified valve or calcifications in other arteries in the chest as well. It doesn't clinch any diagnosis by any means, but it may just give you an idea as to how severe the problem might be.
But on the other hand, I guess I would want to just say for our audience that they're not that reassuring either. I think you've already said that, but
No.
I just want to emphasize that if you had a normal EKG and a normal chest X-ray, we wouldn't be so reassured that
No,
you
absolutely not. These are not diagnostic tests. They're sort of they're part of the evaluation, but by no means do they exclude or include the diagnosis by any means. The next test that I would talk about, which there's a picture of as well in that graphic, is something referred to as an echocardiogram. It's in the lower left corner, also referred to often as an ultrasound of the heart. It's very simple to do, which makes it a very appealing test. There's really no downside to it. There's no risks to the test. It's an ultrasound, so some gels applied to the chest wall, and the technician has a probe which delivers ultrasonography, and you can acquire really nice images of the heart. And in addition to that, you can learn a lot about velocities within the heart and turbulent blood flow, and if there's leakiness in the heart valves. And so I think that actually is really the mainstay of our diagnostic armamentarium, if you will, of what we can do to diagnosis, that you can very clearly see these leaflets of the heart valve thickened and not opening well. And then you can assess how severe it is.
Right, very specific measurements we have a capacity.
Yeah, very potent, very good, very accurate, very reliable way of assessing how severe the blockage is. Essentially, the way we do that is you can measure the speed of blood going across that valve. The faster it is, the more narrow it suggests that it is. And it's more complicated than that, but that's essentially what we're doing.
Sure.
And it's a very useful test to assess how severe the...
I would say it's the test. I mean, I think you're...
Yeah, right. I'm understating
I think you're being
it.
almost modest to say...
Yeah.
I mean, if of all the 4 tests that you showed, if I was...
that's the test,
If I was stuck
absolutely.
on a deserted island and I
That's
could only
right.
have one test, that would be the one I'd want. I could live without all the other tests.
Yeah, absolutely, absolutely. It's the gold standard test that we use nowadays, absolutely. And the beauty of it is it's very simple, and it's done without any downside to it. There's no risk to this
Very
test at all.
safe, yes.
Yeah, absolutely. And you get enormous amounts of other information as well. And the last test that's on that graphic is something referred to as a cardiac catheterization. And you can tell by the picture alone that's certainly something more invasive. And I think nowadays, truthfully, because of how good echocardiography has become, that that test is largely used when one is possibly going to surgery, because it can also do a lot of different things. And maybe I should have you describe this a little bit more, since this is your specialty. You're an invasive cardiologist. But what kind of things can we get out of this?
Well, I would say practically the way this is used is not as a diagnostic tool, but I think you said very well, just as a final step before going to the surgical procedure. Because the only question we really are answering at the catheterization is, we already are confident we need the valve replacement based on the evaluation by you, the cardiologist, and the echocardiogram. So we put those 2 things together. So the question is, when you have your heart valve replaced, might you also need something else done, like a heart bypass of your blocked arteries?
Right.
So that's really it's almost not even the aortic valve we're looking at, although we are. It's really less important for that as it is for this other piece.
Yeah, absolutely. And I always tell people, if you're going to have open heart surgery for your valve, it makes sense to also know what the coronary arteries are, just so that you don't show up a year later with another problem with the coronary arteries. So absolutely. I mean, I guess that brings us sort of to our next point in this discussion, maybe the treatment for this.
Sure.
And
well, maybe can we just, there's a picture you have a beautiful graphic of actually pictures of what these valves look like.
Yeah.
So let's put that graphic up, and I think that would be great if we put that graphic up and then just briefly talk about...
There's actually a different one than this one that shows a couple of surgical samples from the operating room of a...
Aortic stenosis is the title of this graphic. And just to briefly say, maybe you and I could talk about the size of this valve and what we think about briefly the size of the narrowings and that kind of thing. What's significant in that regard?
Right. So the way, just to orient the viewers to this, on the left side of your screen is what is referred to as a typical aortic valve, the tricuspid aortic valve. And you could, I think you can appreciate there are 3 leaflets, and in the middle is a very small, narrow opening. And those leaflets are all calcified and thickened. And on the right, there are only 2 leaflets. That's the bicuspid aortic valve, as it's labeled. And those are also thickened and restricted as well. And we can make measurements before one ever ends up in the operating room with echocardiography or with catheterization of how narrow that, or how narrow that valve really is, how poorly it opens.
Yes.
And I don't know if it's worth getting into the specifics of what the numbers are, but...
well, I generally tell patients that we use a number of 2 as the normal size.
Sure.
Just for those who are technically interested, centimeters squared.
Yeah.
So that's a little less than an inch squared is the normal opening. And we would say that that's normal. And then take it away from there, what sort of beyond that.
There's a lot of different gradations you can use, but one could talk about mild, moderate, severe, and critical. And you can often consider, to make it simple, anything less than 1 centimeter square, you can often consider a severe aortic stenosis.
So about half normal size.
Yeah,
okay.
and then after that, it's becoming semantics at that point,
right.
The debate between severe and critical, and
right.
0.7 centimeter square, 0.8. I think largely what becomes important are your symptoms.
Mm-hmm.
You could have aortic valve area of 1 centimeter square and have no symptoms.
Right.
It's important to know and requires frequent and regular follow-up with your doctor. And I don't think we touched on that, and maybe I'll deviate off this
sure.
topic for a second on that. And that once one is diagnosed with this problem, it does warrant continued evaluation. So certainly visiting with a cardiologist makes sense when one has maybe moderate aortic stenosis, because there's certain signs and symptoms that we really are in tune to and trying to pick up, but also that ultrasound test, the echocardiogram. Once you have it, depending on how severe it may be, you may get it in 2 years again to check on it again, or 1 year, or if some symptoms change, maybe sooner. So that's a very important test to follow up upon, absolutely. It's the gold standard way of following up upon it. But getting back to that graphic, I think we finished talking for the most part about that.
I think we did.
Yeah.
So I think you've done a really great job summarizing that we have patients that come to us because usually a heart murmur, possibly signs and symptoms, identifications with the ultrasound or echocardiogram. We talked about how the valve narrowing can be specifically and accurately measured with the ultrasound, and then followed until it becomes either so severe that we get worried about it, or it becomes severe enough and there's associated symptoms.
Right. And
then where do we go with that?
And the symptoms are very important to pick up upon, because once one develops these symptoms, there are well-documented statistics about how long you can go before you run into a real problem, in other words, dying.
Death, yes.
Without any sort of intervention upon. So if you develop chest pain suggestive of angina, pressure,
right.
heart failure, fluid retention, shortness of breath, or fainting, those are pretty ominous signs that tell us that it's time to get this valve fixed.
Sure.
And if not, you have a high chance of passing away within the next 2, 3, 5 years,
right.
in that range.
Well, I'm older than you, so I'll tell you that when I was training, I was told that in many times the risk of death is higher waiting for surgery than it is for surgery, because there was less availability for cardiac surgery 20 years ago, 30 years ago, and while patients waited a week or a month or 2 months for surgery, there was higher death rates than just going ahead and having surgery.
Yeah, I'd like to think, I don't think that problem exists
now,
certainly.
I agree.
That, especially where we live or
Sure.
where we're located, we have
Right.
access to,
Right.
to tremendous
I
amounts
agree.
of things.
I agree.
So anyways, getting to the treatment stage of this. So it'd be great to be able to take a medicine for this, and really there's no medication that treats this. There's some hope or some thought that this class of medications called statins, cholesterol medicines, that maybe it could influence the progression of aortic stenosis. There's some small little studies looking at that, but nothing so powerful that we would lean on that as a real treatment for this. So that's something that's being looked at. But the real mainstay of treatment is surgery. And there are some centers that are dabbling in aortic valve repair, where they go in, debride it or get rid of the calcium and fix the valve, and that's it. But that's not so common. Typically what happens is the valve has to be replaced. And there are different types of replacements or prostheses that we use. They divide mechanical valves, which are made up of steel and other components. And then there are tissue valves as well. And they can come from a lot of things. People refer to them as pig valves, so porcine valves, or bovine valves coming from a cow, or other species as well. And there are different reasons why one might choose one or the other. I think one important thing to note is that if you are to have a mechanical valve in place, you are committed to lifelong blood thinning medication. So that's an important distinction.
A medicine commonly called Coumadin or warfarin.
Right, and that's, there's the pro to that type of valve, though, the benefit, though, is it's thought that it lasts longer than
forever.
The tissue valve. Right, essentially forever. And the tissue valves are getting better and better, lasting longer and longer. Okay. And the tissue valve is something that doesn't require the blood thinning or the Coumadin medication. So that's a nice option for maybe people who are older and don't need it to last 40 years, I think 25, 30 years or something. So surgery is really the only option for this. And it's becoming a much more well-tolerated procedure. As every year passes, there are less and less invasive approaches, as with all cardiac surgery. And in fact, there are even now things being looked at where you could do it in a catheter-based approach. And maybe I'll have you explain a little bit about that, since you're the...
Well, I think we're running out of time, so I think that we might be able to just sum up with that, to say that I think you've done a really beautiful job summarizing this issue of aortic stenosis, a problem that occurs more commonly in older folks. It happens with increasing frequency with each decade of life. We see it commonly in our practices. Aortic stenosis is a problem of a narrowing of the main outlet valve. The main symptoms we worry about are anginal chest pain or pressure or heaviness in your chest, shortness of breath or fainting. It's identified with a heart murmur as a first step, but ultimately with that ultrasound or echocardiography, and then careful follow-up by your cardiologist with ultimately a referral for some kind of corrective measure, which at this point is surgery, which is a great therapy. Patients recover, do very well in the long run, and we think are the right things to do. And I'm sure you saw recently in the paper, Governor Arnold Schwarzenegger of California just celebrated his 10th anniversary after aortic valve surgery. So there's a representative of a great success in aortic valve replacement. So thanks very much, Dr. Srivastava, for joining me and reviewing this topic. So thank you again for being with us for this edition of Matters of the Heart on Aortic Stenosis. Please join us again for the next edition. For Pentucket Medical Cardiology, I'm Seth Bilazarian. Thank you.